adjustments that oncology pharmacy professionals had to make during the pandemic. I will obviously specifically talk about the UK perspective, but it's pretty much, I think, the same things happen across the world. These are my disclosures. So I'll be talking about the overall impact of COVID-19 on cancer services. And then I'll specifically talk about the impact of COVID-19 on oncology pharmacy practitioners. I'll go into a little bit detail about what we did locally at our center. And then we'll talk about some of the challenges and opportunities that COVID-19 has created. So let's look at the overall impact of COVID-19 on cancer care as a whole. So patients with cancer appear to have an increased risk of mortality and morbidity from COVID-19. There's been delayed diagnosis because of reduced screening, but also reduced diagnostics. And also there was a reluctance for people to present themselves to healthcare services. There's been changes to treatment pathways. So treatments have been modified or stopped or even deferred. A lot of staff have been redeployed to work to respond to COVID-19. And of course, most of you will know that clinical trials came to a halt. If it wasn't a COVID-19 study, it was pretty much suspended. Looking at the UK's perspective, so cancer is one of the biggest killers in the United Kingdom, and it affects 1 in every 2 people throughout their lives, with an incidence of over 300,000 new cases each year. It's becoming increasingly clear, specifically through the first wave, that the biggest threat to the healthcare system in the UK after COVID was actually to cancer services. And it's the entire cancer pathway has been disrupted, all the way from screening programs all the way through to treatment. So when you look at screening pretty much was halted. Referrals, so urgent referrals and routine referrals also dropped. Cancer diagnostics, we were doing fewer CT scans, fewer MRI scans, and a drastic drop in endoscopies, because endoscopies is an aerosol forming procedure. In terms of treatments, there was a third drop in chemotherapy attendances, a small drop in radiotherapy, but surgery was pretty much halted almost by 50%. This slide shows 30% of cancer clinical trials were suspended, but from my own experience, pretty much all cancer studies came to a halt in our center. So let's look at the impact of COVID-19 on oncology pharmacy practices. In order for me to prepare this slide, I thought it would be useful to do a literature search looking at guidelines or recommendations specifically on oncology pharmacy practice or practitioners. Kumud helped me with this, so I'd really like to thank Kumud for helping me get started with this literature review. We identified 52 sources with an additional 2 that we had come across in our readings. And eventually we only looked at 6 studies which met the inclusion criteria. So we found 4 guidelines, 2 from France, 1 from England, and 1 from Saudi Arabia, and 2 surveys. So looking at the first survey, this was done by the International Society of Oncology Pharmacy Practitioners, and they did a screenshot survey between the 10th of April and the 22nd of April, so pretty much in the first wave. And they were looking at the impact of COVID-19 on the delivery of cancer therapies. They had 42 practitioners respond to the survey from 28 countries, so this was definitely a global survey. The graph on the left-hand side shows you some of the highlights of what they found in their survey. So oncology pharmacy services changed. 82% of respondents said that their services had changed. Pretty much most, or 50% of respondents said that they use digital technologies for communication. So most things went virtual. There was a lot of disruption to access to medicines, and that's all the way from anti-cancer medicines to anti-infective medicines and supportive care. There were lots of workforce changes and lots of changes to the structure in which oncology pharmacy services run. Some practitioners had changes in scope of practice, so some of them were deployed to work in ICUs. And what was most interesting for me in the survey was the mental health impact on practitioners. So 61% of people felt that 50, I don't know how to put it on slide view. So 61 people felt that there was extremely likely to have COVID-19 would have a mental health impact on practitioners. Looking at the second survey, this is from the European Society of Oncology Pharmacy survey, the survey from the European Society of Oncology Pharmacy. This was an online survey, which was a longitudinal survey for about 12 consecutive weeks. And they were looking at looking specifically at hospital pharmacists and community pharmacists. And they had specific questions for each of those groups. They had over 1,000 respondents from 60 countries. And during the survey period, up to 38% of the respondents reported that their staff were infected with COVID-19. The respondents also talked about decrease in planned operations for cancer and decrease in chemotherapy admissions. There was drug shortages throughout, so both hospital pharmacists and community pharmacists talked about drug shortages. And some of the community pharmacists also experienced personal protective equipment shortages. This survey concluded, or the authors of this survey concluded, that the work of the oncology pharmacists were affected quite drastically during the pandemic. So looking at the guidelines now, so there were two French guidelines. The first French guideline was looking at improving pharmaceutical care across all pharmacy activities. So all the way from compounding to clinical care to delivery and administration of medicines. It was developed by 7 experts and it was assessed by 31 independent reviewers. The authors came up with 26 recommendations and they organized this into 8 themes. The first 3 themes were around hygiene, so hygiene for patients, staff, and hospital. They also talked about adaptations of resources, pharmaceutical care, stock management, so a lot of stock monitoring because of shortages. They talked about technology, so not only did they talk about virtual clinics and virtual consultations, but they also talked about access, giving people access to remote working. And they talked about crisis management and how pharmacists were critical in being at the table when it came to crisis management and how to manage things during a crisis or during workforce shortages. At the time of writing, so this guideline was published in June, on June the 15th last year, and this was the first guideline that was published to the author's knowledge, and it represented a consensus of pharmaceutical practice in French hospitals. Looking at the second guideline from the French pharmacists, this one was specifically targeting the clinical oncology pharmacy services, and they reviewed, the aim was to review recommended national and international guidelines. They also wanted to look at drug-related issues with antineoplastics as well as anti-COVID-19 drugs, and they wanted to produce some practical guidelines for clinical oncology pharmacy practitioners. They summarized a really nice table of international and national guidelines broken down by cancer types, and which were all sort of consensus-based. Not much data comes through evidence-based. These authors produce a really nice comprehensive pharmacokinetic and pharmacodynamic drug interaction tables for all the then used COVID-19 drugs. So we probably know that some of these drugs are no longer advisable to use in COVID-19 treatments, but these tables do exist, and they compared the anti-COVID-19 drugs with oral anti-cancer therapies. And they came up with some practical guidelines for clinicians, and they talked about maintaining knowledge and lots of collaboration and using telemedicine through their practice. Their conclusions were all around continuous service adaptations, sharing and learning, and using opportunities in the pandemic, like learning new skills specifically around the drug interactions. The third guideline was from the Saudis. So this is the Saudi Oncology Pharmacy Assembly, and they made recommendations specifically on cancer treatment modifications, and they were developed by 12 expert oncology pharmacy practitioners. They came up with 8 recommendations. Now, a lot of this is evidence-based guidelines, and they quote a lot of the evidence that they use to make decisions about these things. So they explained when adjuvant chemotherapy could be delayed, when you could use extended schedules, when you could switch IV to orals, when you could do some home administrations, when it was appropriate to delay stem cell transplantations, when it was appropriate to discontinue treatments. They also talked about the use of telemedicine, and some strategies to minimize patients visiting the pharmacies. So they talked about posting medicines, they talked about couriering medicines, and they talked about a 24 hotline where patients could call in and talk to somebody about their queries about medicines. They also provided practical strategies for managing treatments during the pandemic, and they suggested a national collaborative approach to care while minimizing exposure and guaranteeing quality and continuity of care. And the fourth and final guideline I'm going to talk about is from the British Oncology Pharmacy Association. So this was actually a position statement published in September. And here the authors outlined the clinical and operational responses during the pandemic. And this was specifically targeted at hospital oncology pharmacy services. So they divided their position statement into 2 sections. So the clinical response, they spoke about implementing national guidelines and treatment modifications and how to introduce new therapies. They spoke about changes to supportive care, and they also mentioned new and enhanced roles during the pandemic. The operational response, they talked about using home care, couriers, drive-through, and self-administrations to help reduce the footfall of patients through the healthcare service. They talked about virtual consultations and virtual meetings. They mentioned physical distancing guidelines and monitoring medicines supply because of shortages. And they also suggested to clinical trials should be suspended. They concluded that it was important to evaluate service changes through the pandemic. And they also felt that it's going to be challenging to meet the anticipated surge in demand, and also it's going to be challenging to restart clinical trials when the pandemic is eventually over. And they made recommendations on steps to undertake for future service planning. So just to summarize the 4 guidelines, the 2 French guidelines. So the first one was around pharmaceutical care. The second one was specifically targeted for clinical pharmacy. The Saudi guidelines provided lots of evidence-based treatment modification guidelines, and the British summarized the clinical and operational responses during the pandemic. What I thought would be important to talk to you about is also what patients felt and how patients felt during the pandemic. The ENABLE study is an ongoing study which is looking at understanding the importance of self-management support in patients living with cancer, which is treatable but not curable. The investigators will be conducting longitudinal interviews to explore how perspective change over time. They'll be recruiting up to 30 patients, but what I'm showing you here on this slide is what I'm showing you on this slide is an insight into the sudden impact of COVID-19 on patients and carers. So it's fair to say that we all experience some kind of restrictions in our daily lives because of the pandemic. But this anxiety and uncertainty seem to be magnified in people with cancer who have a limited time to live. Routines were disrupted, and patients were no longer able to participate in normal activities. Patients felt they were well supported by healthcare teams and they were supportive of phone consultations, but had concerns about long-term impact of changes to treatment. Carers were really worried about bringing the virus back home, and other family members couldn't come over and help because of shielding guidelines, which were sometimes a bit confusing. And this put an extra burden on the carers living with the patients, and carers felt they had less access to support and respite. The authors felt it was critical for healthcare professionals to recognize some of these effects on patients during the pandemic. And they felt that healthcare professionals should take the time to prepare for difficult conversations with patients about the impact of COVID-19 on treatments. So locally, what did we do? So the first thing that our organization was looking at is safety first. So we minimized visits as far as possible. We went to pretty much everything being telephone clinics. Treatment was modified. So a lot of treatment was discontinued and a lot of treatment was modified. And I'll go into details a little later in a few slides down the line. We had gave patients options for phlebotomy. So we offered them district nurses to do the phlebotomy. And in terms of pharmacy specifically, we were offering home delivery of medicines, and we set up a drive-through pharmacy. This was during the first wave. In the second wave, we had to stop the home delivery because it was quite resource intense and we didn't have enough resources to actually maintain it during the second wave. Looking at patient safety, all patients were reassured that every precaution was taken to make sure the environment had the lowest risk possible of catching the infection. All patients were offered personal protective equipment as soon as they entered the building. We had a no visitor policy on our inpatient ward. And we had no accompanying person for patients that had face-to-face appointments. Our day unit was by appointment only, and this allowed the nurses to screen patients over the phone 24 hours in advance. Any patients presenting with symptoms or any staff presenting with symptoms were offered tests. We had COVID-free zones. Our inpatient ward was pretty much a COVID-free zone, so we did not admit any patients who was COVID positive. All our waiting areas followed the physical distancing rules. Looking at safety for staff, all staff were offered PPE and hand sanitizations. Staff were also offered scrubs if they wanted to use them. All meetings were virtual. Everything was happening on MS Teams. We had, in the second wave, all staff were given home testing, and we test twice a week, and we upload our results onto a central system. We were offered flexible working and remote working if possible. All staff had to undergo risk assessment to see if they had additional risks which mandated them to work from home. We had, in the peak of the pandemic, we had daily and sometimes twice daily communications from the chief medical officer. And we also, there were a lot of programs being offered on staff health and well-being. So the NICE guidelines, so these are the National Institute for Health and Care Excellence guidelines. We pretty much mandate to use treatments only approved by NICE. So NICE very early on in the pandemic issued guidelines on what we needed to do to deliver systemic anti-cancer treatments. And the purpose of the guideline was to maximize safety for patients and make the best use of NHS resources during times of constrictions or restraints. There's a really nice section on prioritizing patients who require SACT or systemic anti-cancer therapies. It goes from priority level 1 to priority level 6, and priority level 1 is mainly these patients are curative and have the highest chance of success. So this helped clinicians to focus who should get chemotherapy during the direst moments of the time in the pandemic. So these are some of the treatment changes we made in our organization. So we offered less myelotoxic regimens for AML. AML treatments usually require a long inpatient stay, but we managed to reduce that to an outpatient type of regimen. We stopped all maintenance rituximab and obinutuzumab in follicular lymphoma. We switched all bortezomib for myeloma to oral therapies for myeloma. We were allowed to offer or other oral options earlier on in the treatment algorithm, specifically for myeloma. We were allowed to increase the schedules of drugs like pembrolizumab and nivolumab. And we rationalized the dosing of our steroids, because steroids can cause decreased immunity as well. Some of the challenges of doing or making these changes is there's a lot of governance processes, and each regimen or each new therapy that's used needs to be approved by the trust or the hospital. And each regimen that we set up on the electronic prescribing system also requires a local protocol. And this takes up a lot of time, especially when you have one or two members of a very small team in isolation. It was sometimes quite difficult to keep up with the pace of changes. We moved from subcut or IV preparations pretty much to almost half our patients being on oral therapies. And this potentially would have a lot more drug-drug interaction. So we were doing a lot more drug-drug interaction checks. Some staff felt some of the treatment algorithms were getting confusing because they weren't sure what line of therapy was allowed and what the next line of therapy was going to be. We changed supportive therapy as well. We stopped bisphosphonate infusions. We used a lot more GCSF, so glomerular cell stimulating factor, to boost white cells. Pre-pandemic, we were only allowed to use it for curative intent. But during the pandemic, we were allowed to use it across the board. We also made use of a lot more antimicrobial prophylaxis, and we were using all the antiemetics we could to avoid patients coming into hospital for nausea, vomiting problems. But using all of these meant that we might potentially have drug shortages because everybody wanted the same thing. And we had lots of issues around potential drug interactions, and we did have to recommend lots of changes specifically for antiemetics. Not everything was bad. There were lots of benefits for patients and lots of opportunities were created. So patients loved the virtual consultations because it meant that they weren't waiting for hours and hours in crowded waiting rooms. They had a wider access to new therapies. And we were sharing, so across our patch, we were sharing stock with other hospitals that were running short. So it meant that our patients always had the stock that they needed. In terms of practitioner benefit, We had regular virtual communications. We also had to create education and training material that wasn't face-to-face, so we made everything quite self-directed for our induction programs. We had developed a fast-track system for approving the drugs in the trust. And there was a lot of sharing and collaboration amongst the sector when it came to guidelines and procedures. And a lot of the staff made good use of the health and well-being programs that were on offer. So let's look at the challenges now overall to cancer services. So reversing the impact of the pandemic, I think, is going to be really challenging because we're going to need more staff to deal with the capacity, with the backlog. We need to probably take into account patients and carers and their mental well-being. We need to restart clinical trials. And as yet in my center, we have not restarted the cancer clinical trials yet. Everything's undergoing a review at the moment. We will need to monitor patient outcomes after the treatment adjustments because of the pandemic, and improving cancer outcomes in the long term is probably going to be quite challenging. Opportunities for cancer services, well, there's been a lot of collaborative working and a lot of sharing of information, which is helping to plan the recovery. There's been a lot of developments in training programs for effective remote consultations. We've learned a lot of lessons from how COVID-19 studies have been fast-tracked, and hopefully in the future we can use those same strategies of fast-tracking cancer clinical trials as well. We've had a lot of access to a lot of new therapies, which we probably wouldn't have had access to if it wasn't for the pandemic. There's talk of creating clean sites or COVID-free diagnostics and surgical sites. We've made a lot of use of mobile buses, so bringing care close to home. And telemedicine, I believe, is definitely here to stay. Through my readings, I've just come up with some of the key research recommendations. So we probably want to look at the effectiveness of remote consultations, not only from a healthcare professional perspective, but from a patient perspective as well. We'll probably want to, or we'll need to evaluate service model reconfigurations. Patient outcomes needs to be assessed because we've adopted lots of interim treatments and we should be comparing them to the approved standard care pre-pandemic. And COVID-19 revealed lots of health inequalities, which we should address in the future. So just to summarize, I've gone through the overall impact of COVID-19 on cancer care, looked in detail at oncology pharmacy services and gave you some examples of what we did in our local area. And I've also talked about some of the challenges moving forward, but also some of the great opportunities that this pandemic has created. I'd like to thank you for listening to me, and if there are any questions, I'm happy to take them.
Thank you so much, Kavita. That was an excellent presentation, and shocking to see all these numbers of how much all these treatments really stopped and things like that. I think we knew that it was happening, but I didn't realize that the numbers are actually so big in terms of the impact on cancer care. Is anyone else on the call with a question? If you want to unmute yourself and ask the question. And in the meantime, I was going to ask you, why were there such a big shortages in the cancer drugs? Because I can understand with supportive care drugs that they were used in COVID units and things like that. But why specifically was there such a shortage in cancer drugs itself?
I'm glad you asked that question because we were going through Brexit. And we were having some challenges getting drugs across from Europe. So drug shortages is an ongoing thing in the UK. And during the pandemic, things got a little bit worse, only because I think it was added on to Brexit.
Okay. No, I think we in Canada have it at time to times too, and patients get switched for treatment because of shortages. But I didn't realize that it was also the same time as Brexit. Anyone else with questions? Kristen.
Thank you, Kavita. That was a really excellent presentation. So thanks for providing the overview. I just have a question for you about maybe just your thoughts or your opinion on the evolution of where you see virtual care going, specifically with older adults, because, you know, it seems that we found in some of our COVID research during the pandemic that there are mixed opinions about it. And I just wanted to first clarify if you're using, when you say virtual, do you mean telephone visits or do they have some sort of, you know, online like Zoom presence? And just maybe your general thoughts about it. Thanks.
So in my center, we mostly use telephone clinics because our IT is still being, the department's still restructuring. So we've had changing all our computers, but we haven't got to video. So for some patients, they do use video, but I've not used video. We mostly use telephone clinics. So a lot of the patients, from my experience, they like the telephone clinics simply because they don't have to wait for long hours in a crowded waiting room. They also like the telephone clinic because they can invite their family members to join in on the call. And for some patients, the carer is actually on the call and not the patient themselves. But I agree, for some patients, this doesn't work. So patients, there is one particular patient that I'm thinking of where pre-pandemic, his whole support network was in the hospital, and he used to come weekly for blood tests. So it was almost like an outing for him to come to the hospital. And when we went virtual, and I used to see him every now and then in the hospital, I used to ask him how he's getting on. And the thing that struck me when I spoke to him was he always mentioned the loneliness. So I think for some patients where they live alone and they don't have a whole network of family members supporting them, sometimes the hospital and the hospital staff themselves become their whole network. So I think telephone clinics are great if you have the technology, if you have the know-how of how to use it. But for some patients, I think it's probably not the right thing. And I think we need to have systems whereby we have options for patients.
Other questions for Kavita? Otherwise, I'm going to ask, as other people are thinking, what are these mobile buses? Because that sounds like a great opportunity to bring the treatment home. It sounds like something we need in Canada. How does that work?
So we have a bus that's equipped with like chairs and drip stands, and you have chemotherapy trained nurses who will go and deliver chemotherapy and administer the chemotherapy within these buses. So they have this bus like sitting in the car park of a supermarket, and patients are then given appointments to come to the car park of the supermarkets to have their chemo administered. So it's closer to patients' homes, and it's also a non-healthcare setting because it's only for a limited number of patients. So up north, they did use this quite a lot because some of the cancer centers were not clean. They were like COVID ridden. So they felt it was important to get the treatment out into the community as opposed to asking the patients to come into the hospital.
That sounds great. And how many patients at the same time would it be in a bus? Would it be one patient? Was it by appointment, or is it more that they can come in?
It's usually by, I have to say, I don't know that detail, but it is generally by appointment.
Oh, that sounds great. It sounds like something we need in Canada, where our patients also travel huge distances to come to cancer centers. Mm-hmm. Anyone else with questions on the call? Or comments?
Hello.
Hi, Nico.
Hello, everybody. Thank you very much, Kavita, for the wonderful talk. I have a question. has your trust implemented used self-administration? Have you been sending patients, subcutaneous treatments, injections to? I'm thinking about the denosumab, Herceptin during the pandemic. We've been doing that in our trust. And what are your views for in the context of older patients? What's your impression, your experience? Thank you.
So to start with, we considered doing self-administration, but we didn't really get a large uptake from patients. We had like one patient who was interested, and at the time, the consultant who was leading on this project didn't feel it was feasible to just offer it to one patient. In terms of self-administrations in older patients, I think if patients are capable of doing it, or if they have carers who are willing to do it, then I think it's a good idea. But we've got to remember or think about how we're going to communicate, or how the patient or carer is going to communicate back to the hospital to say that they've administered the drug, so that the record keeping can be accurate. Because as you know, we've got to submit SAC data set on a monthly basis to Public Health England. So we've got to make sure all our ducks are in a row. So make sure the patients had proper training, or the carers had proper training, make sure they understand how to administer, how to dispose of, how to store the medicines, and then how to communicate any issues back to the healthcare team. I think it's a good idea, but unfortunately in my patch, we didn't get a lot of uptake from our patients.
Thank you. And Nicolo, does it work for you to have patients, older patients, to self-administer?
Yes, I have to say I had a few concerns. We've been doing that a lot. In breast oncology. I'm thinking about, again, the denosumab, trastuzumab. You really ought to select patients right, okay? And also the caregiver. All the dose that they need, and they're being compliant, what we would normally do in a personally some slight concerns about this specific aspect. Home delivery, I think, has been a great opportunity during the pandemic. Also in my hospital, we've been doing that a lot with oral treatments, tablets being couriered at home of our patients, blood tests taken at home, or we've been using also our home care service, so dedicated nurses going at home of our patients to take blood tests, to give treatments, but self-administration.
Oh, we may have lost him. I'm not sure if he is still on or not.
Can you hear me?
Yeah, now we can hear you again.
Oh, sorry. Did you guys get what I said? I'm not sure.
No, we missed. You were frozen for me.
Sorry. I'm relying on the hospital Wi-Fi, which is not great. No, thank you, Martin. I just say that for all we've been using it a lot for our patients in my hospital. So asking them to self-administer in the breast cancer patient population. But to be honest, as Kavita said, patients and caregivers as well, and really educate, instruct the patient because you really want to to make sure that they're getting all the dose that they need. the other end, I think, home care, home delivery services, couriering drugs at home of our patients. We've been doing a lot during the pandemic. That's a great opportunity for all the patients as well. But with self-administration, I have personally some slight concerns. So I think you really need to be confident that you are asking the right patients to do that, rather than use this. Today is quite bad here.
Well, thank you. It's interesting to hear how different parts of the world have adjusted so differently. Are there any other questions for Kavita? And Kavita, are your clinical trials up and running again, or they're still closed? Because that was one of the first things they opened up again in Toronto.
So all COVID-19 studies are up and running, and we keep getting more and more COVID-19 studies. The cancer studies are very slow, and it's taking a lot longer to get them up and running. But we have issues around like the clinicians having enough time, because we've lost a few consultants over the last few months, and they've been struggling to keep up with the workload anyway. So let alone the trial patients, the non-trial patients as well, has been quite a struggle. So there's multiple factors why our cancer clinical trials haven't been up and running as we would have liked them to.
Thank you. Yeah, I think that was in our wave 1, it was shut down, but after that they opened them up again, and now we have wave 3, and in Toronto particularly it's been quite bad. So all the surgery except everything that's very urgent, the rest has all been shut down for by medical directives that no more surgeries are taking place. But I haven't heard that the clinical trials were shut down again. Any other questions? But it would be good for a comparison study at the end to see how different countries handled these differences and the impact of patients. So hopefully we don't have a next pandemic, but that we can see what is the better way of going about it and how that is impacted. But for us in Toronto, home care totally was closed down. We couldn't access home care anymore. They stopped nurses and personal support workers from going into patients' home because of lack of PPE, and now we can access that again. Any other questions?
I've just one question. I'm sure it's across the board. I suppose when the pandemic began, we stopped all visitors like yourselves. No extra kind of personnel were allowed in, like caregivers with patients. They had to attend the day wards on their own. With all the mask wearing as well, there was kind of big issues around communication. I felt it, particularly with people with maybe hearing impairments that would rely on maybe, visual kind of cues. But did you have any kind of big issues around that, or did you come across much of that, Kavita, in terms of, did you put any structures in place for that?
So some patients, even though they had been told that it was a telephone clinic, some patients just turned up, and we obviously couldn't turn them away. And when they were asked why they came in and why they didn't rely on the telephone call, they would say, well, I'm hard of hearing, or I don't have the right telephone. And we did experience some like that. And then we had, I remember one pharmacist talked to me about, she had a patient who she was trying to do a telephone clinic to, and it just didn't work out because he was hard of hearing. And when he came face to face to the clinic, they made him wear a mask, and everyone was wearing a mask, but he relied on lip reading. So it is challenging, because whether do you ask patients and do you yourself take off your mask to facilitate somebody lip reading you so that you can communicate better? I think it's quite challenging. I personally haven't had so many challenges, but I know colleagues of mine have had quite a few challenges with patients that were hard of hearing.
Thanks.
Any other questions from anyone? Then I would like to thank you. Sorry, my kids' school is started again on the background. I want to thank everyone for joining us today. And thank you, Kavita, for this lovely presentation. I think it really gives a good overview of how you very creatively adapted the pharmacy practice to that, and lots of useful things to think about. So thank you everyone so much for joining. I have recorded it. My internet was a little bit unstable, so I hope it worked well, but we will post it on the SIOG Nursing Allied Health website, so that everyone who wasn't able to join us live can view it shortly. And then, of course, last but not least, our next webinar will be May 25th. I still have to send it around, but it will be on nurses' role in shared decision-making. And it will be done by Hanneke van der Wal from the Netherlands with her geriatrician, Dr. Suzanne Vesters. And so they will present the results of their project where they worked to integrate nursing in the shared decision-making process. So I hope everyone can join that as well, but I'll send an invite to everyone after I receive their bios, etc. Thank you, everyone, and stay well and have a lovely evening, Kavita, and have a good day for us on this side of the pond.
Daddy, can I have a question? Daddy, the first.